Hello, this is Katie Bodine. I am presenting hyperthyroidism and thyrotoxicosis today. Just as a general overview, the thyroid gland, it functions on a negative feedback suppression from the brain. So it's an actually straightforward, easy pathophysiology review. The thyroid gland produces T4 and T3. Most of T3 is converted to T4 peripherally and goes back to negative feedback to the thyroid releasing hormone, which then suppresses or stimulates the TSH. So, of course, TSH is released by the anterior pituitary gland. Picture's worth 1,000 words, isn't it? Okay, in general, when we discuss hyperthyroidism, you'll also hear thyrotoxicosis. Hyperthyroidism or thyrotoxicosis, it's composed of a spectrum of clinical findings that is consistent with thyroid hormone excess. So these symptoms are a result of overproduction of thyroid hormones. Hyperthyroidism is described as an excess from the thyroid gland. So this is a hypermetabolic condition. It's associated with elevated levels of free T4 and free T3 and a depressed TSH, right? The negative feedback loop is working. TSH is not stimulating. It is going on its own. Thyrotoxicosis can be produced from another source or condition. So patients with thyrotoxicosis have hyperthyroidism, but not the other way around. Okay, conditions, for example, these are those thyroiditis, confusing diseases that have phases of thyrotoxicosis, and then they have a phase of hypothyroidism, radiation induced. This can be from cytotoxic medications. Big offender is amiodarone. As far as how much of this you'll see in your population, not nearly as much as you're going to see hypothyroidism, but again, you're going to see women at risk here, as with all diseases of the thyroid. The predominant age here is a little bit different. It's actually in the second and third decades for the autoimmune diseases, and then toxic multinodular goiter is going to be more common in older patients. As far as risk factors or associated conditions are concerned, genetics are a thing here. Risk factors, of course, family history, genetics, especially on the maternal side. Again, being female, if you have another form of autoimmune disorder, you are more likely to have an autoimmune issue with your thyroid. Associated conditions, again, autoimmune diseases. Down syndrome has a link with hypothyroidism and iodine deficiency. As far as the etiology or the pathophysiology goes, there are several reasons to have hyperthyroidism. The most common is going to be Graves' disease. This is autoimmune thyroid disease. It has some associations with diabetes, pernicious anemia, and vitiligo. Family history is important here. And you also hear it called diffuse toxic goiter. So this is about 60 to 80% of your hyperthyroid cases. That's going to be patients in their second and third decades, and commonly have a family history. The other high incidence is going to be from a toxic multinodular goiter, TMNG. This is about 15 to 20% of cases, more common, as we said earlier, in elderly. And this is due to what is thought to be a TSH receptor gene abnormality. Not 100% sure why this happens. Toxic adenoma is a lower percent. This is when you hear the term hot nodule. This is a point mutation in a TSH receptor gene that just gets triggered and causes increased hormone production. Other causes are thyroiditis, as discussed in our thyroiditis lecture, and then, like we said, medication. Your approach to diagnosis is going to be our usual approach, a good old-fashioned history and physical. We are looking for signs of thyrotoxicosis, so it's hypermetabolic state. We are revved up. This is where our energy production is exceeding our needs, causing weight loss, no matter how much they're eating. They're hot, they're sweaty, they might even have a low-grade fever. They have, constitutional-wise, they have increased weakness and fatigue. So unfortunately, they don't get super strength from this. They're going to be hungry. They're going to have non-purposeful weight loss. They might like it. I've had patients refuse treatment for hyperthyroidism because she enjoyed the weight loss aspect. Not healthy. And again, you want to go over their medications, make sure they're not on interferon alpha, amiodarone in particular. Picture's worth 1,000 words. So in our hypothyroidism lecture, we saw a picture of the cold lady. She was miserable. Pretty much everything opposite that hypothyroidism has. Hyperthyroidism is opposite, right? So hypothyroidism, hypometabolic state. Hyperthyroidism, hypermetabolic state. So in this case, the name does us some good here. So we have a nervous, anxious person. They might be a little bit labile with their affect. They might even have a psychosis if this has been going on a while. I have had patients, unfortunately, that didn't have good primary care come in comatose. It was a reason for altered mental status in the emergency room. Memory, concentration's off. They're hungry. They might even have diarrhea because everything's moving fast, okay? Opposite of hypothyroidism, they are going to be oligomenoreic, or they might even have amenorrhea. And then, of course, everything's revved up, so the heart rate's up. They will be at risk for having atrial fibrillation. In terms of physical exam findings, they have Graves' disease. They're going to have that bulging eye look. Their hair is going to be sparse. It's going to be thin and fine. Finger clubbing is a rare sign, but they might be tremulous. Here's some other physical exam findings. Pretibial myxedema is found only in Graves' disease, so that's a very specific, very sensitive finding, as is the exophthalmos. Those two together can almost guarantee that diagnosis. They may have a little bit of lid lag. They are hot, tachycardic. They may be prone to recent fractures. They may have some muscle wasting on exam. They're going to have very fast DTRs. Children will have some linear growth acceleration. Everything's fast, so is their growth. And they're going to have more problems with their eyes. Done a lot of thyroid talk. So what is our differential diagnosis? This could be post-viral thyroiditis. or postpartum thyroiditis. So we want to make sure we elicit those issues in our history. Hashimoto's thyroiditis, as you know, has a hyper and then a hypothyroid phase. Do they have an anxiety disorder? Is this diabetes and they're dry? Pregnancy and menopause pheochromocytoma is extremely rare. Carcinoid syndrome, and actually, what's interesting is excess biotin intake. So biotin can cause false positives in some assays for thyrotropin receptor antibodies, so it can be a misdiagnosis of Graves' disease. So just remember that fun fact if you can. That's enough about that. As far as workup goes, so you have a history of physical that is concerning for an underlying endocrine issue. You'd like to confirm that diagnosis. So step one is establish the diagnosis. So the TSH is once again our best initial diagnostic test. If you take away nothing else, just run a TSH. A level less than 0.1, or you might see units per liter, so that's 10, is confirmatory. The TSH it's very sensitive and specific for confirming suspected thyroid disease, and then once again your free T4 will be a marker for severity of disease. Here is the first time that we will be measuring a free T3 if the T4 is normal, because about 5% of patients with thyrotoxicosis may have just an elevated T3 and have a normal T4. So this is one case, our first case in all our thyroid lectures where you are sending a T3. Antibodies against the thyroid stimulating hormone receptor, the TSHR. This is a new one you haven't seen yet. We talked about anti-TPO and anti-thyroglobulin antibodies and talk about Hashimoto's. This one is specific for Graves' disease. It's an autoantibody that can mimic or block the action of TSH or be functionally neutral. So the most specific antibody for Graves' disease is going to be your TSHR antibody. Over 80% patients with Graves' disease will have this, and this is what differentiates between Hashimoto's and Graves' disease. As far as studies go, where do we start here? You may not need any studies. A thyroid ultrasound is not always required, but it may be used to distinguish nodular forms of Graves' disease from nodular non-autoimmune causes of hyperthyroidism. It can also define nodules or a mass. Is this just hypertrophied tissue, or are these actual nodules? The radioactive iodine uptake test, it is not diagnostic for Hashimoto's because it's an inflamed post-acute state, and so coming with that, you might have increased vascularity. All other thyroiditis diseases have decreased uptake, so just keep that in mind. It also provides an anatomic picture of the goiter and functional information about hormone production. So two different mechanisms of hyperthyroidism can actually be distinguished on the radioactive iodine uptake. A high radioisotope uptake indicates excess de novo synthesis of the hormone, and a low uptake indicates inflammation or destruction of thyroid tissue. So the increased release of preformed hormone into the circulation is not actually from this particular tissue. Our other imaging, it's going to be rare. You probably won't be ordering this if you're in primary care, but this is your PET scanning. This is usually used to look for metastases. Here's an example of the radioactive iodine uptake scan. And there are classic pictures that you will see of each disease. So normal should have just this kind of pretty patchy, call it like a butterfly look. If you're making a lot of new hormone, you have hyperactive tissue, as hyperthyroidism suggests. So you're going to have increased new hormone synthesis. So you are taking up that iodine. Those cells want that iodine for more thyroid hormone production. Okay, so just keep that in mind. So you don't have to really memorize it if you understand how it works. A toxic adenoma, you see in the bottom right here, you see one huge, large hot spot. Okay, it is putting out thyroid hormone. If you look at the toxic multinodular goiter, it's as it looks. So you see multiple hot nodules here. You're also going to have some quote-unquote cold nodules. That's going to have low uptake, which means it's not producing cases of thyroiditis are not going to have high uptake because it's inflamed, angry tissue, and it's not productive. This is just another picture worth mentioning. Again, they're describing the hot and cold nodules here, and so the table on the left gives you ideas of incidences of high uptake. Again, if it's homogeneous, it's the Graves' disease, it's a diffuse toxic goiter, right? So the whole thing is not working well. So you're going to have a homogeneous uptake. Adenomas, all goes to that one spot. Multinodular, hot and cold nodules, multiple spots, and thyroiditis is going to have generally low. As far as treatment considerations go, the decision of which patients to treat and how to treat really should be individualized here. Observation may be appropriate for patients with mild hyperthyroidism. This is your TSH that's closer to the 0.1 or the 10 range, or if they're presenting without symptoms or not bothersome symptoms, they're young, perhaps have low risk of complications, which is AFib or osteoporosis. Just note that anti-thyroid medication is contraindicated in patients with thyroiditis, so you want to make sure you don't have a patient with thyroiditis here and you rule that out before you start these medications. Recall from that lecture, the treatment of thyroiditis, it's not a permanent condition, and it's just supportive. As far as Graves and toxic multinodular goiter goes, we will choose between antithyroid or ablation of the thyroid gland. Last line across the board for almost all of these problems is going to be thyroidectomy. This is a risky procedure. There's a lot of nerves and vessels involved. There's a really high risk of damage to the recurrent laryngeal nerves, and the risk of secondary hypoparathyroidism comes up here. So as far as medication goes, our symptomatic treatment is going to be with our non-selective beta blockers, propranolol and atenolol. If they have elevated heart rates, we need to prevent AFib from occurring, and it'll make people feel better. Again, just pointing out the definitive treatment to Graves, you might start the beta blockers and then plus the anti-thyroid medications, and then go down on the beta blocker after you've got that hyperthyroidism controlled. Also, you might want to start them with a beta blocker until their radioactive iodine treatment has worked and they're now hypothyroid. They're going to come off those beta blockers. So as far as the antithyroid drugs go, these are your thionamides. The mechanism here is they inhibit multiple steps in the synthesis of T3 and 4, so it leads to a gradual reduction in the hormone level as your stored hormone levels are depleted. I will note that this is effective for new onset mild Graves' disease, small goiters, but remission of Graves only occurs in about 40 to 60% of patients within 1 to 2 years of therapy. So antithyroid therapy may be stopped or tapered after a period of time, really looking for the disappearance of that TSH antibody is going to be a hopeful sign that remission will perhaps occur. Pearls here is that methimazole is a drug of choice in non-pregnant patient. It's low cost, it's cheap, has a longer half-life, has a lower incidence of a granulocytosis, and less liver dysfunction. PTU is preferred in pregnancy because it's safer, less teratogenicity, but you're going to have to watch those LFTs. We need to follow up every 4 weeks until they're euthyroid, and again, remission within 1 to 2 years, 40 to 60%, but about 50% of these people relapse at 1 year. As far as definitive treatment goes, the radioactive iodine treatment, this is going to be, this is number one, this is most common. Most people don't want to mess around with medication, they just want this problem taken care of. However, don't promise them no medication, because what happens when you essentially ablate, you destroy the thyroid gland, you are going to be permanently hypothyroid. Okay? Radioactive iodine sounds really scary, but the bottom line is there's no greater risk of future thyroid cancer or other malignancies with this treatment. Pregnant women will have no problems with pregnancy once their euthyroid state is achieved. The way this is given is that it's a one-time, one-day treatment. So I-131, it's concentrated into the thyroid tissue. It induces extensive tissue damage, which results in decreased hormone production within 6 to 18 weeks. Most of these patients, again, they're going to be permanently hypothyroid eventually. So basically, they have iatrogenic hypothyroidism, and they're needing lifelong T4 treatment, and they really need to be thinking about this, and this is going to be an important discussion, particularly as if socioeconomic status changes, they lose their insurance. Maybe it's safer that maybe they don't know if they can afford T4 for their entire life, so they'd rather try the other medication and not destroy their thyroid, and maybe there's a chance they could go into remission and then not have to need lifelong therapy. Also do note if they have the Graves', I can never say it right, the ophthalmopathy that comes with Graves', they need to be treated with prednisone before and after. You're going to probably be working with an ophthalmologist, make sure they get exams before and after their ablation treatment. And these people are going to be pre-treated with methimazole because you want to have them as euthyroid as possible, so that they don't have issues afterwards. So they'll hold it for a few days prior, and then they'll resume it after until their thyroid has completely been destroyed. As far as monitoring, they're going to need their thyroid tests repeated every 3 months. Also, if they're on medication, like we said, LFTs, check CBC, make sure you're not missing agranulocytosis. And then after radioactive treatment, thyroid function at 6 weeks, 12 weeks, 6 months, and then annually until they're euthyroid. Just note that if you are treating them, they're now hypothyroid, and you're treating them with T4, your TSH may be undetectable or remain falsely low for months, even if they're euthyroid. So you really have to kind of follow the T3 and T4 at that point. But overall, the prognosis is good. This is a very treatable condition. Just takes a little bit tweaking and individualized care, and prepare your patient for that. They're going to have a few visits ahead. Complications of hyperthyroid, again, this is rare, but it's potentially life-threatening. Imagine a hypermetabolic crisis. They're going to be extremely ill, they're hot, they're tachy, they may have arrhythmia, their altered mental status, they have nausea, vomiting, they have seizures. So they're going to need an ICU level of care and aggressive treatment, and generally having endocrine on board, so they may be needing stabilization and transfer to a facility that can have an endocrinologist on board. Again, in surgery, as discussed, you can have nerve complications and hypoparathyroidism. Complication, but it's also kind of a known, I would say, more of a side effect of having radioactive induced therapy is you're going to be hypothyroid, most likely. Graves' disease has a high relapse rate, and again, all those things that come with untreated disease is listed at the bottom. Cardiovascular mortality is real. Okay, Katie, there's a lot of tests and a lot of things here. Can we wrap it up? Okay, I went ahead and just kind of gave this little quick references. It kind of brings them all together. Graves versus toxic multinodular goiter versus thyroiditis or toxic adenoma. These are all high. You have hyperthyroidism. Okay, so they're going to present symptomatically. Graves is not subtle. They're coming in, they've got myxedema, their eyes are popping out of their head. People have probably commented on it. It happens it kind of comes on fairly quickly. They don't feel good, and the weight loss is pretty significant. So if they're hot, they're revved up, high iodine uptake. On the labs, they are going to have those antibodies. Most likely, you're going to treat them with beta blockers and a definitive treatment with either drugs or iodine. Surgery is pretty rare. Again, toxic multinodular goiter, you are going to have an older patient. They're going to have a big thyroid. You're going to be able to palpate. They're going to be bumpy. This is going to be a slow, low onset. This is something that's acute, and they're going to have that nodular uptake, and the treatment of choice is actually the radioactive iodine treatment. Maybe surgery if they're having obstructive issues, and they're going to be on a beta blocker. As for your toxic adenoma, pretty similar to the multinodular goiter. They're going to have a solid focus of an intense uptake, right? Because this is one toxic adenoma, not multinodular. It's going to be a hot nodule, the rest of it suppressed, and the treatment of choice is similar with the radioactive iodine, or they might need surgery for excision of this. And you're going to treat them with a beta blocker, but removing this is definitive, as with the toxic multinodular. Thyroiditis, they are not going to have high uptake on their RAI uptake scan. They are going to have Hashimoto's is the exception. They might have increased vascularity on ultrasound if you decide to do an ultrasound on them. The onset varies with thyroiditis. Remember, we have you can refer for each subcategory of painful versus non-painful thyroiditis. Just refer to that lecture for the presentation of the various disease states. I think that's it. I will do a brief video that just kind of summarizes thyroid function tests, since it can be a little overwhelming and confusing, and I hope that's helpful. Please reach out if you have any questions or concerns. Thank you.